Coming up on Being Well, Dr. John Nadeau, General Surgeon from Paris Community Hospital Family Medical Center, is here to talk to us about hemorrhoids and treatment options. We'll learn more about a surgical procedure that is less invasive and less painful with an easier recovery time than more traditional methods. We've got that and more just ahead on Being Well. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston. Thank you for joining us today for Being Well. My guest is Dr. John Nadeau from Paris Community Hospital. Thanks for coming over and talking to us.
Thanks for having me.
Tell us a little bit about your background. You've been at the hospital about a year. Where were you at before that?
Well, before this, I came from Arizona. I was there for a few years. I was looking for a practice that I felt like I was needed a little more, and this was an area that had a need. Prior to that, I'm originally from Maine and trained in Pennsylvania by the Philadelphia area, and then we moved to Arizona. So this is, I guess, my second place to practice.
Okay, and you're a general surgeon at the hospital. What does that mean? I know it means different things depending on what kind of hospital you're at, but at Paris Community Hospital, what does that entail?
We try to take care of anything that, well, a surgeon is, by training, we cut things out or cut things. So anything from simple dermatology procedures, from taking off little moles to skin cancers, all the way up to doing bowel surgery. Majority of my practice consists of doing things like hernia, gallbladder surgery, appendix and colon type surgery, or I'm doing colonoscopies and upper endoscopies, going the opposite way. Do breast surgery, not reconstructive things, but more if someone has breast cancer or lumps that needs to be taken care of. That's the predominant type of practice that I have there.
Okay. Well, we know that you specialize in hemorrhoid surgery, and it's a topic we were how do we go about this, because it's not something people really want to talk about, as you well know. We're going to get into the surgical aspect and just a little bit about what you do, but let's actually talk a little bit about hemorrhoids. What are they?
A hemorrhoid, it's kind of a hard thing to describe, but it's basically a space that is just underneath the top layer of the inner layer of your bowel and your anal area that fills up with blood. Okay, so you have circulation that comes in, it comes from your bowel and it goes into the hemorrhoid and then from the hemorrhoid it goes out through veins. And but what happens is over time, maybe because of the poor diet, we have a low fiber diet, okay, so people strain to go to the bathroom. When you're straining, you're forcing more blood into this area, so it makes the area get larger. You fill it up and it makes a bigger cavity. So that's basically what a hemorrhoid is. Okay.
Now we hear a lot of times pregnant women will get them because of the extra weight. Yes. Are there other populations or people who are more affected by them than others?
The hemorrhoids are very rare with younger people. Most of the time it's either someone, like I said, someone has low fiber, poor diet, they're straining, they're constipated. It tends to happen with the older population. They've been around longer. And it could be that could be a function of just because as you get older, your tissues aren't as supple or they're not as strong anymore, so you start to lose some of that, and the area may start to expand easier. Okay. But as for other populations specifically, nothing that we know of.
So they can be uncomfortable, painful. Can they be life-threatening ever, or lead to other things?
Hemorrhoids are really rarely life-threatening. They're more of a hassle to deal with. As for life-threatening, there are hemorrhoids that can get pretty complicated, very large. If there's going to be life-threatening, it's most likely a hemorrhoid that's more internal, which I didn't discuss that yet, but and if they get large enough, they can get twisted and they can get necrotic and you could possibly get an infection there. And that can be life-threatening, but I personally have never seen a life-threatening hemorrhoid.
Okay, I was going to ask you about internal and external. We got the chart here. Can you kind of explain the difference between an internal and external hemorrhoid?
So what we have is, when you look at the anatomy coming in, okay, this is the outside here, this is inside the bowel. And what happens is the skin, this is like normal skin from the outside, and as it comes in, this is your muscle, okay, so a little sphincter that controls things. When the tissue out here has a lot of nerve endings in it, and that tissue is very sensitive. There are certain places on your body that tend to be more sensitive, your lips, your fingertips, down here, okay? And then once the tissue goes in, there's a little area that has a little wavy line there. This is a little more obvious than a lot of times I see it. So that line here is what's called a dentate line. So whenever you have external hemorrhoids, they're from this little line out, and then if you have internal hemorrhoids, they're from this little line up.
Okay.
Okay. So the external hemorrhoids are the ones that usually hurt, and the internal hemorrhoids, a lot of times you may not even know you have them until you have symptoms, and it's usually from bleeding.
Okay. So you had mentioned earlier that, sometimes our poor diet causes them. That's one cause. Are they hereditary? If your mom and dad had them, will you maybe have them?
To be honest with you, I don't believe they are hereditary.
Okay.
I think it's more related to the diet, or if you're lucky to get them, I guess. As for being generation-wise, I think it'd be more related to the diet from the family.
So watch what you're eating.
Watch what you're eating. It's very important.
Fiber.
That's correct.
Okay. So generally, if you experience some over-the-counter medications can help alleviate them. Are there prescription medications that can be?
There are some prescription medications that are probably a little stronger than what you get over the counter.
Okay.
And they help with the swelling. To take the swelling down if you have a hemorrhoid attack, let's say, and it hurts. Well, a lot of the pain is related to the hemorrhoid being filled up with blood and stretching, but you also get some swelling that's just the tissue has gotten swollen, so this helps with that. There are also medications that have a little bit of numbing type of medication, so that helps take the edge off of the pain that you have down there.
Okay, so if you've never had them before, maybe you had them for the first time, and you said you have an attack, how long generally will that take for that tissue to shrink if you use some over-the-counter medications or some prescriptions?
It varies per person.
Okay.
I've seen them in the office where people will start with an episode and they'll take the medication to help shrink it, and it may go away in a day or two. But then there are people that have hemorrhoids that are usually there even if they're not swollen. So it's kind of hard to say how far down they'll go because if they're there all the time.
Okay.
So, but for the swelling part, hopefully in a couple days you start to feel better.
Okay. So there are surgical options available. At what point, well, I should ask this first. At what point should someone see their doctor?
Well, if you have bleeding, okay, from below, a lot of times it may be hemorrhoids. Okay. But when bleeding from below is not a normal thing, and there are other sources for bleeding. Okay,
I think about colon cancer.
Colon cancer is a big deal, but there are also diseases. You have Crohn's disease. You can have malformations of vessels inside your bowel that may be bleeding. Diverticuli might bleed. So there's a lot of sources that could be bleeding, and you want to rule that out.
Okay.
Okay. So if you already know that you have hemorrhoids and it's already been proven, and then you have bleeding, that's probably fine at that point to treat them as hemorrhoids. But if you don't really know why you have blood there, you need to be checked out by your physician. But as for once you have the hemorrhoids, when to get treated by a doctor is when they start to cause you to have issues that you just can't control at home.
So real quick, I know that a lot of times like dark brown blood is more a sign of something else. Is hemorrhoid blood more red?
Red, the hemorrhoids tend to have bright red blood.
Okay.
A lot of times people will have blood on their tissue when they're wiping. That's the majority of the time that I hear about it. Or they'll go to the bathroom and they'll have blood in the toilet. a lot of times the blood in the toilet is not as bad as they think they're hemorrhaging, but just one drop of blood in a toilet is actually not as much blood as you think it is. It looks worse.
So doctor, what if the blood is really dark brown?
Okay, so if you have dark blood, usually it means the blood has been somewhat digested. Okay, so that tends to be an issue that's further up the bowel. Okay, so it can be anywhere from your stomach all the way down to in your small bowel to maybe part of your colon, where you first start having your colon. Okay, but bright red blood tends to happen further down the bowel line because it hasn't had time to be digested or absorbed or worked with by the colon.
Okay. So at what point then do you, as someone seeing their doctor, when is surgery an advice for people? Surgery
is usually the last thing in the chain of treatment. So when you have hemorrhoids, first you want to prove you have hemorrhoids. So you're going to see your doctor and he'll say yes. You may need to undergo a colonoscopy prior to anything else, just to make sure, or to make sure that they are hemorrhoids, that what's bothering you.
Okay.
Once you do have the hemorrhoids, to see your doctor is when what you're doing at home is just not doing it. And that means a few months of treatment usually. They're going to do things like fiber, they're going to do things like the creams to try to reduce the size, and usually the fiber is a big deal. Over time, the hemorrhoids hopefully should resolve, or at least be manageable. Okay, but if you can't manage them, now can't manage them means you're having a lot of flare-ups and it really hurts a lot. You've got a lot of hemorrhoids on the outside. You got bleeding that keeps recurring. If they do blood tests and the bleeding you're seeing, you're noticing that the blood levels are a little bit low. Those are all indications that we got to start looking at surgery. Okay, when the medical stuff has failed first, and it's usually treatment for a few months at least to try to treat it medically, because surgery doesn't always go without possible complications. So.
Okay. So there's several surgical options. Can you talk about the more traditional ones? There's a rubber one,
rubber banding,
and then we'll get into the one that you're doing.
Okay. Well, there are things that you can do that are not in the surgery suite. Okay, so you can do things in the office. Some people can do the rubber banding, which is basically it's for internal hemorrhoids, because the internal hemorrhoids, if you do something to those, they don't hurt. Okay. If you did it on the external hemorrhoids and you put a band on it, that's going to hurt a lot.
Might be a bit uncomfortable, I would imagine.
It would be. So that's really reserved for the internal hemorrhoids, and that's basically done with a special instrument that, if you could think of it as it sort of sucks the hemorrhoid into itself. And then there's a very tight rubber band that gets put around it. And what happens is the rubber band stops the circulation from the hemorrhoid, and over time the hemorrhoid will just fall off. Okay. There are other options that you could do. One is sclerosing, which is something I've never done. It's basically injecting the hemorrhoid with a liquid that causes an inflammatory reaction, causes an irritation. And when you cause things to get irritated, when they start to heal off, it sticks together. Okay. So those are more in-office procedures, non-surgical, I would call. The next step for surgery is taking the hemorrhoid out. Okay. Taking the hemorrhoid out it's in a surgical suite. You're sleeping out cold, and we go in and find the hemorrhoid and actually cut the tissue out and take the hemorrhoidal tissue out, and then you go home. But the tough thing with that is it can be very painful.
It sounds painful, to be honest with you.
Yeah, the internal portion is not so bad, but if you get out towards the outside, then that hurts.
Right.
And I've done hemorrhoid resections before.
Okay.
And the difficult thing with that is you tend to treat one hemorrhoid. Okay, so or if you have a lot of hemorrhoids, you can't do the whole area because then you won't have anything left. So it's more of a staged procedure. We do a portion of it and let you heal off for a few months and then come back and do another section. Personally, with my experience, when I've done one, people have never come back for the second.
I can't imagine why.
Yeah, it's a hard thing to treat. Right. Pain-wise, it can be a few weeks, and the pain coverage is a combination of different modalities where we'll give you pain medication to go home with, we'll give you some lotion, ointment to put on there to help feel a little better. Soaking in a bathtub is helpful. It helps with the circulation and the healing process and relaxation down there. and giving you some stool softeners so it's easy to go to the bathroom.
Right.
All these things sort of play together to try to heal off the surgery, but it's not an overnight, I feel better tomorrow type
Right.
thing.
Well, and not to be gross, but it's an area that generally gets used every
It
day. So if
gets
you've had
used.
surgery down there,
That's right.
you can't really, I mean, if you break your arm, you can kind of avoid using it. You can't
That's correct.
avoid
And-
that part of your anatomy.
And it's a tough thing for people to deal with, because when they have surgery, they don't want to go to the bathroom.
Right.
So they say, no, you got to go, because if you get constipated, it's actually worse to go to the
Yeah.
bathroom afterwards.
Right.
So that's when I switched over to the procedure that I'm doing now.
Okay, and it's called THD, and it has a really long name, and I'm going to
It's-
let you tell us what that is.
So transanal hemorrhoidopexy dearterialization.
Wow.
Big word. Big words.
We do have, I want you to walk us through the surgery, because we
Okay.
actually kind of have a graphic sort of it. It's not graphic in nature, so you can kind of tell us how this surgery works.
Well, the way it works is, the concept is your hemorrhoids are fed by blood from arteries that come in from alongside your bowel, okay? And there's 6 of them, and they're located roughly like the odd numbers on a clock. So if you looked at the anus, it'd be roughly at 1, 3, 5, 7, 9, 11 o'clock,
Okay.
So the treatment is find these arteries before they feed into the hemorrhoids and tie them off,
Okay.
okay? And the way this works is, there's a device that I have, and the procedure itself is, you go to the surgical room, so you're out cold sleeping, okay? This is not an awake kind of a procedure. And I use a special device that allows me, if you can see this image here, there's a little black dot right here, and this is a Doppler probe. So a Doppler probe works where people might have known it, where, let's say, they're
Doppler radar for weather?
well, not Doppler.
Okay.
Well, it could be, but more familiar is when the woman is pregnant and they have a little probe they put on, and they can
Sure.
hear the baby's heart. You hear that whooshing sound. Same idea.
Okay.
So what this does, allows me to find the artery, and when I find it, the device allows me to put a stitch at the right depth in the right location to tie off the artery.
Okay.
Okay, and once that artery is tied off, which is this part of the image right here, I use the same stitch. If somebody has a lot of hemorrhoidal tissue that's loose, okay, some people, it's not as loose in certain areas, what I'll do is I'll take the same stitch and just take a little bit of the tissue while coming out, and then when I tie both ends together, what it does, it pulls in all that loose hemorrhoid, a lot of the loose tissue inside, and it flattens it out.
Okay. So does this work only on internal hemorrhoids, or you do it for external ones as well?
It's supposed to be for internal, but it actually worked well for the external ones, because they're
Okay.
both tied together.
Okay.
So they're both fed from the same artery.
Okay.
Yeah. The limiting factor for the external ones is that if you have a lot of loose tissue, the idea behind putting the stitches, especially when I do that to tie up the loose tissue, we try to stay away from that little zigzag line where the nerve endings change from the inside to the outside, about 1.5 centimeters. So I don't want to, I'm trying to avoid putting a stitch in the tissue that has a lot of nerve endings.
Right.
Okay, and sometimes it's unavoidable, because that line may not be easy identifying. When I try to stay away from that line, I might have a hard time pulling all the tissue in from the inside, but
Okay.
the real treatment is tying off the artery.
Okay. Because then it loses its blood supply?
It loses blood supply, and we do all 6 arteries. We don't selectively pick one and try to treat, because you really don't know how that's feeding in.
Okay.
So we do all of the arteries all the way around, and try to tighten up the tissue all the way around as much as we can.
So unlike the other surgery you mentioned, this you can get in and do it all at once, and
All at
people
one time.
generally don't have to come back.
Correct. There's about a 3 to 4% chance you may get hemorrhoids again.
Okay.
So roughly 96-97% chance of never having hemorrhoids again.
So is this an outpatient? Are you in the hospital for just that day and you go home that day?
It's completely outpatient.
Okay.
Depending how bad the hemorrhoids are, the procedure may take anywhere from half an hour to 45 minutes.
Okay.
Once you wake up, as long as you're feeling fine, we send you home.
Okay.
Typically, I'll send people home on a stool softener to make sure they go to the bathroom when they're supposed to. I give you some pain medication, and then I don't have to see anybody for about 3 weeks, and then we just
Okay.
to talk to see how they're feeling.
What's so what is the recovery time typically like?
The recovery time, it depends on the patient, and it's hard to predict how they're going to recover. If I had 100 people, I'd say about 25 people are going to walk out of there feeling that nothing's happened, other than knowing they went through a procedure. Maybe 50 of those people are going to have some pain or discomfort. Usually it's a feeling of pressure down that area because we're really wrinkling a lot of the tissue, and that's a sensation of pressure, because just like if you had to go to the bathroom, you feel pressure down there, there's something in there stretching, it's the same idea. So you'll feel the pressure. Every once in a while, there may be a little pain just because of the stitch may be too close to the tissue that I'm trying to avoid, or they may get a little fissure. A fissure is like a little, think of it as a little paper cut on the skin there, and that can hurt. And about the last 25% of the people will have some amount of pain because they'll get some swelling in this area, and that can usually last a week to week and a half. It's a lot shorter time-wise as compared to taking them out, but once they start having their bowel movements, they feel a lot better. Yeah.
So can the hemorrhoids come back after this surgery? Can you get them again?
Maybe 3 to 4% of the people get certain hemorrhoids back. I have had to go back before to take a look, and it never came back. It was other issues that were going on at the time. And if they did come back, the plan would be to go back in with the probe and see if there's an artery that was missed that wasn't tied off. But I haven't had to do that yet, so it's been pretty successful with it.
You've done several of these.
Yeah, I've done several of them here. Yeah, I got my little niche, I guess. I don't know if I want to say your claim
to fame is the hemorrhoid surgeon, but he is.
Yeah, I guess I'll be known for that for the area.
That's okay. Well, and as we were talking before the show, it's something that people don't really want to say, hey, I have hemorrhoids, we're just so funny about stuff like that. And do you think that's why people live with the pain and discomfort for a long time, because they don't really want to say, hey, I have this? I think somewhat embarrassed about it. If you talk to your doctor about it, that's a plus. And then when you come in and talk to me, I see these all the time, so nothing to be embarrassed about. But most people that deal with it probably don't have enough issues with them yet, and they're just managing them. And they probably heard, the stories that having hemorrhoid surgery is a very painful thing to undergo, so people try to avoid the surgery. As long as they can manage it on their own, there's nothing wrong with that. Right.
But at some point, they're going to draw a line and say, I've had enough. And
so what's, of the patients that you're doing the surgery on, can you give us kind of an average age? Are they 50 and up? Or are you doing them on younger people?
Very rarely on younger people. I always have to say mostly in the middle-aged population and a little bit older. So somewhere in the 40 range, going all the way up to 70, even 80 years old. When they get older, most of them have learned to manage these on their own. Most of the time it's the middle population that I operate on. Very rarely do you get hemorrhoids on the younger population. And most of the time, the younger population may get a hemorrhoid flare-up once, and then they never get bothered by it again. So until later on in life.
I thought, as our younger populations, our diets seem to get worse.
Yeah.
You may be seeing younger and younger patients. You never know.
And it's possible, but as right now, I haven't seen that many people for hemorrhoids in the younger population.
All right.
Yeah.
Well, Dr. Nadeau, thank you for coming on and talking about this topic. As I said, it's something that not a lot of people want to talk about, but thanks for explaining it to us in a way that we can understand, and that there's treatment options out there that aren't as painful maybe as they used to be.
They're not as painful as they used to be, yes.
Thanks for coming on. It was a pleasure
to
have you on the show.
Thank you very much.
It's one thing to want to tackle a marathon. It's entirely another to train for one while going through treatment for breast cancer. Meet one such marathon runner for whom the challenge of getting ready was also about getting well.
When you have a cancer diagnosis or an advanced cancer diagnosis, everything in your life starts to unravel.
For Cynthia Sycon, long-distance running is a perfect metaphor for being a breast cancer survivor. Getting there is accomplished one step at a time.
It's very important, whether you're running a marathon or going through chemotherapy, to not think too much, just to focus on what you're trying to do right then and keep doing it.
I would recommend that anyone you know who's making the cancer journey have a buncologist.
Along the way, Sycon has found that others are inspired by her experiences. She talks about why she runs so tenaciously and about her diagnosis in 2010, which doctors in her hometown of Chicago repeatedly missed for over a year.
You have to be your own advocate.
This tumor could have been seen if one simple, different view had been done in mammography.
The latest scans show she's now cancer-free. Moving forward is about moving. A recent survey of Mayo cancer patients found that doctor-approved exercise decreases fatigue and boosts mood. Sycon's oncologist told her, if you want to run, run.
And time again, it turned out that I actually felt better if I stuck to my normal activity than if I just sat on the couch and wallowed in the discomfort.
For Cynthia Sycon, this seems to be the right medicine. For Mayo Clinic, I'm Dennis Stoda.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston.